So with us today, we have Katie Hauck, and Katie is a registered physiotherapist who specializes in pelvic floor physiotherapy with a special interest in the impact of cancer treatment on pelvic health. She is fortunate to work alongside exceptional therapists at Toronto Physiotherapy and talk frequently on how common cancer treatments can impact one's bladder, bowel, and sexual health. Kitty is also passionate about sharing her knowledge and delving into traditionally uncomfortable yet significant health topics. So with that being said, Katie, I'll pass it over to you for our presentation for today.
Great. Thank you for the introduction and thanks for having me today. I'm very excited to talk about everything and anything pelvis. It's a complex area and often kind of a mystery area in the body. Usually when we start talking about pelvis, we get into more uncomfortable topics like bladder, bowel, and sex. And that's basically the focus for today. So any question is not off limits. I'll do my best to answer them at the end of the presentation. Given the nature of the topic, and if there are more questions, I'll leave my email at the end as well. And I'm always happy to answer questions that way too, that might not get covered today. That being said, lots of information to cover. So today we'll chat about the different cancer types that we talk about when we think of the pelvis. So going over a bit of anatomy. Over the next hour, we'll go over the types of treatment, surgery, radiation, and chemotherapy that have an impact on our pelvic floor health. And then more interesting and more fun is what kind of things or challenges might you be noticing from that cancer treatment? And what can you do, or what are the options out there for living well after cancer treatment? With the pelvis, about 23% of new cancer diagnoses for women are in the pelvis. So quite a number. The reason being is there are a lot of things packed into a very small space. So this is where anatomy can be very helpful. On the bottom right of your screen, there's a little bit of a diagram. So we'll go over the different cancer types with anatomy. So if you look on the diagram on the bottom left-hand side, there's that little white structure. That's the pubic bone on the front. So for reference here, if you took your body and cut it into left side and right side, we're looking at a cross-section right through the pelvis. So pubic bone's at the very front, and then the couple little beige structures at the back, that's the tailbone at the back of the body. Sandwiched in between those 2 points, we have what's sometimes referred to as the 3 subway riders. So the 3 organs sitting back to each other. The one closest to the pubic bone is the bladder. That's that kind of wedge-shaped structure with the bladder opening leading to the outside. Bladder cancer is kind of lower on our list of our top 5. So we're often not seeing too many treatment impacts coming from the bladder, but the bladder could be impacted by treatment for other cancers. So sitting right on top of the bladder, we have sort of a pear-shaped structure. Looks like there's little 2 antennae coming off of it. So that's the uterus. Uterine cancer is about our number 2 cancer, so quite a common one that is treated with combination of surgery, radiation, or chemo. Coming off of it, the 2 antennae looking things are the fallopian tubes with the ovaries attached. So ovaries are our main production area for estrogen in the body. So another thing to consider with ovarian cancer treatment are menopause-like effects that might happen if estrogen is removed from the body. And menopause effects are going to have an impact on bladder function and sex life as well. At the bottom of our uterus, that kind of pear-shaped, we do have the cervix. So cervical cancer is kind of the bottom of our top 5. And then below the cervix, that's the vagina leading out of the body. Cancer here is not often common, but treatment for other cancers in the pelvis can have an impact on the vagina as well. Right behind it, we do have the rectum. So the thing that looks like a little bit of a 3 sausage piece. And that's connecting to our colon or our large intestine. So this is for getting rid of waste in the body. And that is our #1 most common cancer that we are seeing in the pelvis. I add on the bottom there, when we combine breast cancer and cancers in the pelvis, this actually makes up almost half of cancer diagnosis in women. The reason we add breast cancer to the list is hormone treatment for breast cancer that's meant to remove estrogen from the body has those same menopause type effects. And menopause effects, as we said, are going to have an impact on our bladder function and sex life. So an important one to consider in there when we're talking about the pelvis. Oh. Going back a step, one thing that I didn't point out on this slide is we do have a very important structure. We have the muscles, or the pelvic floor muscles. So that's the only thing that you can see labeled on the diagram, creating this sort of sling or support system at the bottom. There are quite a number of muscles that make up the pelvic floor, and they have lots of important jobs in the pelvis of creating support, holding everything in. They're also going to be our main muscles controlling bladder bowel function and have an important part in our sex life as well. So a group of muscles doing quite a number of jobs in our body. So the effect on our pelvic floor is not so much from the cancer itself. It's more the side effects of the treatment for those cancer. So we're really looking at what are the surgical, radiation, and chemotherapy effects that are influencing how the pelvic floor is functioning. And we can't forget the estrogen effects of menopause. So whether that menopause is surgery-wise, removing the ovaries, that removes the estrogen. If it's a hormone treatment like we see with the breast cancer group, or even naturally occurring menopause, radiation-induced or chemo-induced menopause. So delving into that, with surgery, anytime we have surgery going through the abdomen or pelvis, we do want to consider the effects of scars. So particularly scars in the abdomen, we have something called peristalsis, which is the way our body moves waste through our colon and out of the body. If scars are slowing down that rate that waste is moving out, we may be having struggles with constipation following surgeries. One common surgery that we tend to see more side effects resulting would be a radical hysterectomy. So uterine cancer was the #2 one on our list. Radical hysterectomy, that's the third picture on the bottom of the screen. So with this surgery, they're removing not only the uterus, but also that cervix that was at the bottom, part of the vagina, and very often both ovaries and fallopian tubes as well. A reason we tend to see more complications from this surgery is it's a pretty big incision that they're doing for this type of surgery. So we have a big scar that we want to consider afterwards. It's also a big support system that we're taking out. So with our 3 subway riders, we're taking out that whole middle system. And our body doesn't like to have empty space. So everything else in the pelvis is going to move around and adjust to try and fill up that space. So this can have an impact on that bladder and bowel that's sitting sort of front and back of that space. With part of the vagina being removed, that is going to shorten. So instead of having a nice long vagina, sometimes with sex, we might get some discomfort now that it's a little bit shorter. With surgeries too, the nerves can get a little irritated during that surgery. And that can impact how the bladder and bowel is functioning afterwards as well. With radiation treatment, there's been such an improvement in treatment over time that it is getting more and more specific, more and more effective, which means on the other side, more of us are trying to manage or deal with the side effects of radiation. With radiation therapy, any and everything that's in that radiation field is going to be impacted. So everything in that field becomes a little drier, less elastic, not just the organ that you're trying to target. So within that field, we can get a lot of scarring or fibrosis, like I said, dryness, and things become less elastic. So the treatment with radiation, it may have been for uterine cancer, but with the vagina being in that field as well, it's also going to be impacted by that radiation. So it can lead to something that we call vaginal stenosis, which is the narrowing and shortening of that vaginal canal. So everything kind of just shrinks in a bit. With the vagina, one thing to keep in mind is our bladder opening is actually slightly inside the vagina. So as things narrow down, if they do close off completely, we can also impact how well our bladder functions as well. With radiation too, one interesting thing to note is that it's something that you don't really see on the surface. We can't see it happening. And the effects of radiation can happen even after you're done radiation treatment, sometimes months or even years later. So chemotherapy treatment is often used along with surgery or radiation. Chemotherapy basically creates dryness throughout the whole entire body. That includes the vagina as well. So if dryness is creating pain, particularly pain with sex, that's what leads us to dyspareunia, which is basically a funky, fancy term for pain with intercourse. If chemotherapy also causes the ovaries to fail or stop producing estrogen, then we're also looking at those menopause type symptoms. Another symptom of menopause can also be that dryness as well. So that leads us into what are those menopause changes, or when estrogen starts to decline, what kind of things are we seeing? So breast cancer survivors that are using a particular hormone therapy called aromatase inhibitors tend to see a lot of the impacts of this estrogen decline, as this type of treatment basically removes a lot of the estrogen from the body. So when estrogen drops, dryness is a particular concern that we see. We also experience something called vaginal atrophy, which is really the thinning, drying, and inflammation of the vaginal wall. So this can sometimes create pain with penetration. If pain leads to our body trying to protect, we sometimes get more muscle tension in the area. Muscle tension then leads to more pain. And sometimes we get stuck in this vicious cycle. When estrogen declines, we can also experience some changes with the bladder as well. So if you're that person on a road trip, typically, back when we could do more road trips, that's having to stop at every single pee break imaginable, having that strong urge to pee. This could be from some of those menopause type changes happening. One little trick to see if there might be lower estrogen in the area is to take a mirror and look on the outside at the vulvar tissues. When there's lots of estrogen, they're typically a kind of brighter pink color. Without estrogen, they might be a little bit paler. So, side effects from treatment, whether it is a combination of surgery, radiation, or chemotherapy, or the effects of that estrogen decline, we typically break into those three uncomfortable topics. So bladder, bowel, and sex or pain are areas. Well, like I said, there's common things that we might have with the bladder. If you're that road trip person, going often, urge to pee, or not being able to control the bladder. Very common stories I hear is you're at a trampoline park, jumping on a trampoline, and all of a sudden have a little bit of pee trickling down your leg. Urinary tract infections are also common, usually with that estrogen piece that we mentioned. Bowel-wise, are you able to fully control the bowel movements? Are you struggling with constipation? These are side effects that are very common after treatment. And last but not least, pain, whether it's pain with sex, back pain, hip pain, pelvic pain. These are all things that are very common. And just because something's common doesn't mean it's something that we have to live with or struggle through. So we'll make sure we go over at the end what are some tips and tricks and things that you can do to overcome these common symptoms. So first, let's chat common symptoms first. So tension in those pelvic floor muscles and sensitivity in nerves. So whether that was from menopause symptoms or radiation or surgery, basically tension in the pelvic floor connects very closely to the bladder. So it can actually trigger this urge to pee. So things you might notice are that strong urge to go, even when the bladder is not full. If you're going very often throughout the day, getting up at night to pee, unless you're over 50, getting up once at night is normal. We can typically sleep through a good 8-9 hour night. And then any loss of urine is a sign that our pelvic floor and bladder aren't talking to each other. So estrogen does have a role in our immune system when it comes to our bladder and urinary tract. So it is something that helps fight off any kind of infections. When estrogen has been removed from the body for whatever induced menopause, we can be a bit more prone to UTIs. So we'll make sure we chat a few strategies around that at the end. So just like we can have leaks with the bladder, we can also have leaks with the bowel. Our pelvic floor doesn't just control the front, it also controls the back. So in that first picture we saw, it did run all the way from that pubic bone to the back tailbone. Awesome news about this is with research, they found a supervised pelvic floor program that included an exam of that pelvic floor was shown to really help in training to control both bowel movements and the bladder as well. So with sex, following cancer treatment, a large number of us notice some kind of change or challenge. In terms of what was the most concern to least concern, sexual desire was top number one, followed up closely by those changes in terms of dryness. And if dryness did lead to pain with sex, dyspareunia as well. And then that shortening of the vagina that happened either from surgery or those radiation changes was the third concern. So male orgasm, female orgasm, it's very different. type of response. We tend to be more like the Rubik's Cube. We're a little more complicated. So to break things down, I have a funky graph and chart at the bottom. When it comes to arousal in females, the best analogy that someone told me is comparing the steps to building a fire. So desire is really your kind of sexy list, what gets you in the mood. This would be building the fire. So laying down the sticks, building up that nice teepee type of fire. Arousal is pouring on the gasoline. Plateau is that lighting the match. The plateau is when all the muscles are contracting, they're on edge, leading up to that orgasm piece. It could be, this would be the fire. So it could be a big fire, little fire, one fire, multiple fires. All fire is great fire. All orgasms are great orgasms. After that, the muscles, we do want to relax and return to their resting state. With desire being what leads us in this response to orgasm, anything that cuts through desire can stop us at the beginning tracks. A sex therapist used a great analogy of gas pedals and brakes. Gas pedal is anything that pushes you towards orgasm. Brakes are anything that take you away. So it doesn't matter how much we tap on the gas if our other foot is fully slammed on the brake. Pain basically acts like a foot fully pushed down on the brake. We could keep tapping the gas and we're not going to move forward. So a lot of our strategies and tips and tricks are around trying to get our foot off that brake, trying to create positive response rather than painful scenarios around sex. So that's what I was mentioning before on the other slide. Desire is basically our sexy list, things that get us in the mood. Arousal are some physical changes we see, so more blood flow, that natural lubrication in the body. Plateau is when our pelvic floor muscles and other muscles in our body are contracting, working really hard. And then with orgasm, there's certain muscles in our pelvic floor that contract very rapidly, rhythmically on their own, and they're the ones that go back to a relaxed state after. So where can things change? Estrogen, if it's been dropping, our threshold to pain actually lowers down. So sensations that may have felt like a pleasurable, just nice touch can start to create a sensation of pain. With radiation, we had that narrowing and shortening of the vagina as well, rather than that nice kind of elastic stretch. So over time, with these two types of changes, we can get pain, whether that's during sex, hours or days after. With physical exams as well, we might have that pain. Challenge with pain in the pelvis is that we can get into this vicious cycle where our muscles tense to protect us. So pain leads to tension, tension leads to more pain, and now we're stuck in this vicious cycle and loop. So our hands-on strategies and exercises are all geared towards cutting through that pain and tension loop and trying to create more pleasurable experiences rather than painful experiences for the body. So last but not least, pelvic or back pain. There's a great study that's now a couple years old now. It's not cancer specific. They did the study in women that were going to kind of a traditional physiotherapy clinic for either low back pain or pelvic pain. And as a part of the study, they did an internal pelvic exam. So how that looks is either vaginally or rectally, they're doing a hands-on exam where they're feeling and looking at all those pelvic floor muscles. So most of these muscles, they're hidden away in the body. They're hard ones to find. We don't often really know what's going on with them. So in the study, they found, looking at the pelvic floor, about 96% of the women had some findings with that internal vaginal or rectal exam. 67% was weakness. So you may have heard of Kegels before as strengthening exercises for the pelvic floor. Traditionally with low back pain as well, our focus was on, okay, we got to strengthen, get a stronger core. That's going to make back pain better. And that's something that worked well for the 67% group. The 84% actually had tension or tenderness in the pelvic floor. For this group, Kegels or strengthening can actually make things feel worse. It would be very similar to if you had a knot of tension in your neck and I gave you strengthening shoulder shrugs, you'd probably be cursing my name. Things would not feel good. But if we massaged out those tender spots, did some stretching, it's likely going to feel better. So depending what the pelvic floor is doing, the exercises or strategies can be very different. I'm not a math expert, but 84% and 67%, you've probably noticed, is a lot more than 100. So there are some women in the study that did have a combination of tension and weakness as well. Okay, more exciting part. What are some things you can do to tackle these side effects from treatment? So next few slides, we'll chat about some hands-on techniques, exercises, whether we're that tight group that wants to lengthen or the weak group that's strengthening, looking at moisturizers and lubricants, chatting a bit about estrogen, and last but not least, preventing urinary tract infections. So, like our neck example, if we have tension in a muscle, finding those tight points, massaging them out can help with relieving that tenderness and tension. So physiotherapists that specialize in pelvic floor, we sometimes call ourselves glorified massage therapists. We're basically using hands-on techniques similar to massaging other parts of the body that are working on releasing specific points of tenderness in that connective tissue or in those pelvic floor muscles. You can see on the bottom of the slide, the picture on the left is looking on the outside of the pelvis. So if this is someone lying on their back, that pubic bone's at the top, tailbone's at the bottom. On the sides are your sits bones, so the bony part in your butt. And all those muscles are parts of the pelvic floor. So we have muscles on the outside. If you look on the right side of the screen, that's now looking on the inside of the pelvis. So we also have a lot of muscles inside as well. And any muscle can develop a point of tension or a tender point. A physiotherapist can be a great resource to help you find your specific points of tension that might be contributing to pain that you're experiencing. They might recommend some self-tools as well. So what you're doing one-on-one with the physio is just a small piece of the puzzle. What you're able to do at home has a big impact on how you're feeling. So there's different tools that they might lean you towards. The one on the bottom left is called a TheraWand, which is basically just a fancy poking device. So it's a nice curved shape. If there's a particular spot that's tight inside the pelvis, that might be up around a corner and kind of a nook and cranny, the curved shape just helps you reach those spots. The picture on the bottom right is one example of a dilator set. So particularly with the changes from radiation, so we get a lot of that scarring, fibrosis, and adhesions forming. Dilators are a great resource to help minimize some of those adhesions forming following radiation type therapy, and also help keep that vagina a little more open and elastic as those radiation treatment effects linger for those months and sometimes years after treatment. There's lots of different styles and types out there. I could get into a real long talk and rabbit hole about it. So if you have any specific questions, definitely ask me at the end. So in addition to hands-on treatment, the tools to mimic some of that hands-on treatment, as a physio, you can't get away from not doing exercises. So there's great exercises that can also help lengthen the pelvic floor. So this is working more on those tight areas. One exercise in particular, instead of a Kegel, which is a strengthening exercise, this is the opposite, called a reverse Kegel. For this exercise, we need to know about another muscle in the body, which is our diaphragm or our breathing muscle. So you can see the diaphragm sitting at the bottom of the rib cage. How this diaphragm works with the pelvic floor is there two partners working together like a piston. So you can see the diaphragm's at the top, pelvic floor is right below it at the bottom. When we breathe in, our diaphragm actually moves down, which creates some pressure inside of our body, and that pelvic floor below relaxes and lengthens with it. So they both move down as you breathe in, and then naturally move up as you breathe out. It seems like such a silly exercise and simple exercise, but breathing and learning to breathe using your diaphragm is a great way to lengthen and release some of that tension in those pelvic floor muscles. One challenge with breathing is, particularly in stressful scenario the world is in today, is you might notice you tend to breathe with your shoulder. So a nice test or trick to try later on your own, if you place one hand on your chest and then one hand on your belly or bottom of the rib cage, taking a deep breath in, try and pay attention later to what hand you feel moving. If you feel your top hand moving, you might actually be a bit of a shoulder breather, versus your bottom hand, you're likely more of a diaphragm breather. If the breathing is tricky to do, or you can't quite picture what the pelvic floor is doing with it, there's other exercises that also work on lengthening and stretching. One example of that is a full squat. So full squat is when you try and get your butt all the way down to the ground. So you're only a couple inches away from the ground. Fun fact, about 1 in 5 people can't get all the way down. If you virtually are connecting with people later, try it out and see, are you one of those 5 that can't quite get all the way there? If you aren't, there's lots of other exercises and options that you can try to get that same lengthening and stretch of the pelvic floor. Other exercise tips for the pelvic floor, sound silly, sex often. Orgasm in particular helps create circulation and blood flow, so it brings all the good nutrients we need to the vagina. Sex, especially penetrative intercourse, acts like using a dilator. So it's one way to reduce how often you need to use the dilator if you're following radiation and have a lot of that scarring that's happening. Catch-22 with sex often is if sex is creating pain, now we're feeding back into that pain, creating more tension, vicious cycle. And if that's the case, looking at other strategies or delving deeper to break through that cycle can be a great option. That leads us to our brain or our nervous system. This is really queen over everything. We can't have a meaningful impact with the other exercises if our nervous system's in that fight or flight, tensing up all those muscles in our body. Particularly if it's tensing up the pelvic floor. We have two parts of our nervous system. We have our fight or flight or sympathetic nervous system, and then we have our relax, rest, and digest, or our parasympathetic nervous system. Anything that taps into that rest and digest is a great way and tool for really releasing tension in the pelvic floor. But once you've gone through all the other steps, being able to better find these hidden pelvic floor muscles, tap into them. Good strategy is picturing these muscles throughout the day. Are you, without maybe even realizing, holding on to tension in these muscles? Or are these muscles nice and relaxed? Are there certain triggers or things in your day that you're noticing these muscles are tensing up with? Picturing those muscles and working on strategies to release tension can be another great tool to have in your toolbox. Other exercises like yoga, tai chi, qigong all have great research and evidence for tapping into that rest and digest nervous system. And back to our deep breathing, which was basically that reverse Kegel exercise we chatted about before. 5 minutes of doing that nice diaphragm breathing is also a way that taps into that rest and digest nervous system. So a great way to ensure that that tension is staying at bay. Exercise really is the best medicine. So we can't get away from being physically active. There's too much great research out there. Not only does it reduce the risk of cancer recurrence and mortality, it's a great way to restore movement without triggering that pain or fatigue. Whatever exercise you're choosing to do, make sure it's something enjoyable. A couple guidelines is minimum 150 minutes per week of either moderate or vigorous exercise. So whether that's your walking, biking, running, whatever it may be. And they did show there's added benefits of strength training about twice a week as well, particularly for anyone that has the menopause type symptoms. So with menopause, we do lose strength in all muscles of the body, not just in the pelvic floor. So keeping up a good strength routine can be helpful as well. To Kegel or not to Kegel? So far, we haven't even touched base with Kegels or strengthening. You can see there's lots of scenarios where strength may not be your go-to, but strength is important. And there are some cases where we do want to add Kegels to the routine. So some signs that Kegels might be the way to go for you is if you're getting those bladder leaks with things like coughing, sneezing, running, basically activities that add load or pressure down in the bladder. That can be one sign. To effectively retrain these muscles, they showed that even one session of a internal pelvic exam, training the different pelvic floor muscles, showed huge significant improvements in ability to control that bladder. Anyone experiencing menopause effects, so whether that was naturally occurring menopause or induced early from cancer treatments, when estrogen drops, we do have an effect on how well those pelvic floor muscles are functioning. So we do lose a bit of strength. If you've had kids or given birth, there might be some history of muscle weakness that's come from delivery as well. Oh, strengthening. With the pelvic floor, like we said, there's lots of muscles that are working together. So we can't pick or choose one over the other. Just like our quad muscles in our thigh, they all work together to straighten your knee. We can't pick out one of them and tell them to do something. That being said, if we're looking to control our bladder or control our bowel, we can direct our attention to either the bowel or bladder area. So with the pelvic floor, we typically divide it up into two triangles or two halves. So the front half near your pubic bone, that has your bladder and your vaginal opening. The back half or your anal triangle has your rectal opening. So if we're more interested in controlling bladder, so we're getting those leaks with the coughing, sneezing, laughing, the Kegel or cue that might work better for you is thinking of stopping your pee. Another cue that works well and sounds very silly is picturing a raisin sitting at your bladder opening, trying to draw a raisin inside. Holding in a tampon feeling is also great for getting that front area. If you're having more challenges controlling bowel movements or getting leaks that way, focusing on stopping a fart feeling might be the better cue for you. Another strange one that works well for that is if you picture a marble sitting at your rectal opening, you're trying to draw a marble inside the body. A lot of these, when you're training them, it's aiming to hold for a good 10 seconds, feeling that contraction the whole time, and then being able to let that Kegel go afterwards. So these muscles, they are meant to be kind of on in the background all day long, but sometimes we need them to also come on very quickly. If we're getting a leak with a cough, it wouldn't help us if it took 10 seconds to get that closing around the bladder. So practicing these faster pace as well, we call them the quickies. That's being able to quickly on, off, turn those muscles. Particularly if we're thinking of our orgasm muscle, also known as our PC muscle, it's going very quickly during orgasm. If we're only training a very slow 10 seconds on, slow off, we're not quite getting that speed that we're looking for. Timing is also going to be important with these muscles. It doesn't help us if our Kegel comes on after we cough or sneeze. We want it to come on before that happens. This is a natural reflex in the body. It's typically automatic. With different treatments, and even after having kids, this reflex can kind of fade away and become less automatic. On the positive side, it's often a reflex that we can train back again if we're working and practicing on timing. A couple things to highlight of when not to strengthen, when Kegels are going to be counterproductive for us. If we've just had surgery, it's recommended to wait at least 6 or 8 weeks just to allow everything to heal before we start strengthening. If you're using a catheter, Kegeling around a catheter can increase our urinary tract infection or chance of getting a UTI. So it's recommended not to Kegel if you're using a catheter. And pain. Pain's usually our sign that there might be some tension going on. Just like with that tight neck, adding those strengthening shoulder shrugs, likely not going to be productive. And working on strategies and techniques to release tension may be a more effective strategy for you. I know we're kind of going over time a bit, so very quickly, moisturizers and lubricants. This is really tackling that problem around dryness. Just like we moisturize our skin in a dry winter, we can moisturize our vagina as well. Usually the effects last for a couple days, so it's not something you're doing every day. And I've listed a couple there that typically get some good feedback. Not all moisturizers are created equal. You want one that's actually going to bind to the vagina and that doesn't have a lot of irritating chemicals added to it. Same with lubricants. That's a great way to add more comfort during sex. So we're giving the brain more pleasurable experiences and trying to get away from more of those painful experiences. Not all of them are built equally as well. I've listed a couple that, again, also tend to get good feedback. So mainly lubricants, you're looking for something that doesn't have a lot of chemicals added to it. Particularly after different treatments, the tissue can be a little more sensitive, so easily irritated with unnatural ingredients or chemicals, and can create more burning or pain. So we want to make sure that the lubricants are a tool you can use that are helping with those painful symptoms and not creating other painful symptoms like burning. So local estrogen for symptoms coming from the menopause effects, this is a safe and effective treatment for most women. That being said, there's not a large amount of evidence for women with cancers that, particularly breast cancer, that responds to or feeds off of estrogen. It can be a great conversation to bring up to your family doctor. And preventing urinary tract infections. With UTIs, it's much easier to prevent than treat if you've ever had one. Reading online on internet, there's often great list of tips and tricks. If I had to highlight one that works really well is drink lots of water. Bacteria can't anchor if we're flushing it out all the time. So lots of water is the best tip. A couple other strategies that you can do. If this is something that you are struggling with, having a naturopath on your dream treatment team can be a great resource for more tailored tips and strategies. So hopefully we covered some common symptoms that you might be experiencing following the different types of cancer treatment, and having some resources or strategies to start on for really living well and living your best life after cancer. Some resources if you are looking for a physiotherapist that specializes in this area. Pelvic Health Solutions lists most Ontario physiotherapists if you're looking for someone in your area. And if you want more research information, you're welcome to check out our website as well. And as I promised, here's my email. If there's some questions that we don't get to today, definitely feel free to reach out to me anytime.